Hey y'all, so I decided to make a week 3 review, and these were just some topics that I wanted to just highlight and make sure you guys know. All right, so consents, really briefly. So there is a paragraph on consents in your book, but I just want to go over what the nurse's responsibility. So an informed consent. So basically, anytime we're doing something with a patient, we need consent. So like when you go through the ER, you'll get like a general consent, meaning like, okay, I consent to you drawing my blood and all that kind of stuff. But informed consents, like for surgery, that basically is when the physician, basically they explain the procedure to the patient, they explain their risks, they explain the benefits. Any question that that patient has, the doctor has already answered it. So your job is, as the nurse, is to witness it or actually get the signature. So when you witness consent, you don't actually have to hear or see the doctor tell the patient that information, but you basically would print the paper off and you actually fill it out. So you would fill it out with the patient's name and what surgery they're getting, and you would go to the patient and be like, did your doctor explain this procedure to you? Do you have any questions? Are you good to go with the surgery? And if that patient says they're good to go, they agree with everything, then you can sign. And the physician will sign it later, and then you just sign that you witness that the patient understands what they are consenting to. Now, if this patient says, yeah, the doctor kind of explained the procedure to me, but I still have so many questions. Even if you have seen that surgery done 50 million times, you cannot disclose that information. You cannot teach that patient about that surgery. You then need to call the physician back. I don't even care if it's right before they're going down their schedule for surgery. If that patient does not understand that procedure, it is up to the physician. It is up to the physician to make sure that that patient is educated. Now, let's say your patient, they understand the procedure, they really have all the questions answered, all that kind of stuff, but let's say they forgot, and then you're able to say, okay, well, this is what you're getting. Oh, I remember that. But if your patient has real life questions like, wait, so you mean to tell me I can die doing this procedure, or I might lose my kidney? And I'm like, wait, you didn't know that? No, we need to go back and call the doctor and have the doctor come explain that procedure to you. So also consents, other consents we get are like blood consents, like blood transfusion consents. So a patient will sign consent, do they want blood? So we mentioned earlier in culture about how Jehovah Witnesses, they will refuse blood. So you will sign a paper that says, I refuse blood, and basically I understand, the consequences of refusing blood. So that's what consent is. Consent is the nurse's responsibility is just to witness it or to just get that paper signed. But it's not our job to educate the patient on their surgery and what they're getting done. So that consent form is a legal document. And based on facilities, it consents last for, it just depends on the facility how long consents last for. You may have to get a new consent if the patient is in the hospital like for months. You may have to get a new consent. All right, so just really quick on incident reports. So incident reports, the biggest thing about incident reports, so let's say you walk in and you see your patient on the floor. You didn't see the patient fall, you just saw the patient on the floor. So you are going to complete an incident report. But in that incident report, you're not going to say, oh, the patient fell. No, I'm going to say, I walked in and I saw the patient on the floor. So a lot of time your incidents reports, those are done in-house, meaning an incident report is for your facility. Your incident report will not go into the patient's medical record. The incident report will not go into the patient's medical record. That is a separate file that just the hospital keeps, because if patient sues or something, if you mention that you completed an incident report, then that lawyer can request to see that incident report. So it's not like you're hiding anything, but your incident report, that is for your hospital. Your medical record and all that kind of stuff, do not mention that you filled out an incident report. And on an incident report, stick to the facts. stick to what you saw. Stick to what you saw. If, like I said, you saw that patient on the floor, you're not going to say, patient fell. How do you know they fell? You don't know they fell. You just walked in and they were on the floor. So keep that in mind. I just want to mention that about incident reports. So make sure you read incident reports in your book. So when it comes to provided orders, like I told y'all in class, that you want to always be checking your orders. So what is an order? An order basically is the task, excuse me, the task that you're going to carry out. So if you have a medication order, if you have an order to do a rectal temperature, that basically is the doctor telling you that you can do this stuff. So it is on page 160, page 160. So you want to be familiar with what your facility says about orders. So if you cannot read, so normally we wouldn't be doing written orders anymore, but if you cannot read your physician order, or let's even make it plain, if you are on the telephone getting a telephone order and you do not understand what your physician is saying, let's say he has a strong accent, you as the nurse, it is your responsibility to tell that doctor, hey, I cannot understand what you're saying. Can you slow it down? So when it comes to telephone, so what is the telephone order? The telephone order is basically when we call the doctor on the phone and we get an order and he tells us the order. The biggest thing with telephone orders is that you repeat it back to the physician. So let's say you call in the doctor and you're telling him that your patient has a fever. So he says, give 650 of acetaminophen stat, PO every 6 hours. Okay, so you need to repeat it back to him. So I'm just making sure you said give the patient 650 milligrams of acetaminophen PO every 6 hours. Is that what you said? Okay, good. So you want to make sure that you are repeating orders back. The physicians, they should be putting their own orders in the computer, but sometimes they don't put their orders in the computer. So you can put it under their name, but they need to come in and sign that order within 24 hours. So a lot of times facilities really don't want you putting in orders, but the physicians are stubborn and they really still ask you to do it. But you want your physician to put in their own order to minimize errors, right? To minimize errors. So mostly I like to only really do telephone orders like if it's 3 o'clock at night. So if I'm calling an on-call physician, it's 3 o'clock at night, I'm really not expecting them to get out their bed, you know? But if that physician is on the floor and let's say he's just talking to you and like, can you put that in? And I'm like, no, I prefer you to put it in because that's your job. So just making sure that you are following the proper channels. Even when you're doing the telephone order, it's also good if you can have another nurse listen as well to you know, to co-sign with you. But let's see what else your book says. And you want to document the order, the time, the necessity of the order, and the doctor who did it. But the biggest thing is reading back to your physician. Reading back the order to your physician. All right, so let's talk about progression of diets after surgery. So you as the nurse, you have a lot of control. So after surgery, remember the patient was NPO, right? So now that the patients come back from surgery, we now want to progress their diet. So the doctor will take the NPO order out and put in advanced as tolerated. So how would you go about this? Because this basically is a free range diet, right? So what first I like to do is I like to start my patient with, I like to start them at the bottom. So I'll start them with clear liquids. I'll see how they do with clear liquids. And then I'll move them to full liquids. And then I'll move them to a soft diet. And then I'll move them back to their regular diet. Or if they were on a carb diet, you know, then I'll move them back to that. So basically, we want to start from the bottom, then move up, right? So we want to start with clear, and then we can go to full liquids, and then we can go to a soft diet. So you're saying, why are we doing this? So during surgery, when you get anesthesia, when you get that tube down your throat, all these muscles are paralyzed. So your patient may have trouble swallowing coming straight off anesthesia. So you may need to do a little quick bedside swallow study on them. You may need to check their gag reflex. So how do you check their gag reflex? You would take a tongue blade and stick it in the back of their throat, and you should hear the ugh. That's your gag reflex, right? So you want to make sure that the gag reflex has returned before you feed a patient after surgery. You want to make sure that the gag reflex has returned. All right. Another thing is also bowel sounds. So remember, before we feed our patient, that they need to have bowel sounds, and we really want them to have normal bowel sounds or hyperactive. So if they have absent bowel sounds right after surgery, that's kind of expected, right, from the anesthesia. But we really don't want to feed them according to your book until they at least have normal to hyperactive. So you may hear hypoactive bowel sounds, and you'll learn about this in physical health assessment and all that, fundamentals 2 or 3, one of them. But just know that if it's hypoactive, meaning they're not absent, but they're barely there, we don't want to feed them neither. Okay? So we're just going to move up the progression of the diets until. So some nurses actually start patients, they give patients a sip of water and then they just put them on a regular diet. It depends on the severity of the surgery. It depends on, how much anesthesia that person had. But each patient is different, but you won't be wrong for climbing up the ladder on the foods. All right, so I posted a video right here about BMI and how to calculate your BMI. So go watch this video. You will have questions on calculating the BMI. You will. So please know how to calculate your BMI. Also, make sure that you look at the BMI chart. If you are given a BMI number, which category would they be in? All right, so nutrition labs. So the two that I want to focus on basically is your serum albumin and your pure albumin. So this is basically your protein levels. So and these levels also show malnutrition. So if you have a patient that serum albumin is less than 3.4, let's say it's 2.8, that could show malnutrition in your patient. They also use the pre-albumin level. That's the one your book uses. And if that number is less than 19, then that could mean that the patient has malnutrition as well. All right, so one of the things that I wanted to mention is that nursing is a interdisciplinary team. So that means we work with a bunch of people, and I think I talked about this in class, but especially in the nutrition, we're going to deal with your registered dietitian. So your registered dietitian, they are going to be the ones that talk about all the nutritional needs that your patient needs. So if they need to be on vitamins, if they need to be on a high fiber, a high carb diet, that's going to be your dietitian's job. Now your speech therapist, if your patient is having problems swallowing, your speech therapist, they're going to be the one that's going to put your patient on a specific type of diet. So and the nurse, you're going to be the one to implement the diet that they're on. So I just wanted to just mention the different disciplinaries that, work together to take care of your patient. So this was just a quick overview of some things that I wanted to just highlight. So just make sure you go back to your book and read up more about the topics that I mentioned here. Also, bring your questions to tutoring tomorrow. Tomorrow's tutoring will be from 10:30 to 12. And I will see you guys next week.